Welcome to part 2 of the No Pain, No Gain pain education presentation. In part 1, you learned that when it comes to pain, there is much more going on in the brain than just signals from damaged and irritated tissues in the body. You also learned that pain is actually an experience created by the brain when it perceives that there is threat to the tissues. In part 2, you will learn exactly what happens in the brain when we feel pain from injured tissues, what the brain has to do for people to not feel pain with normal daily activity, and how adaptive changes can occur in the brain to cause pain to become chronic.
The areas of the pain neural signature are receiving signal all the time. The sensors of the body are producing all kinds of signal that travel to the brain. Some produce nociception. Some produce normal sensory signals. Even the areas of the pain neural signature themselves are producing signals by communicating with each other. It's sort of like these areas are little tubs, with all this neurological activity having an effect on the pain neural signature. All of these signals can be put into one of two categories, excitatory or inhibitory. Excitatory means that these signals start to ramp up the pain neural signature, like faucets filling up the tubs. Inhibitory means that the pain neural signature is being calmed down, like draining the tubs. If you had special eyes that were able to see a person's pain neural signature, you would see that everyone walks around with the tubs of their pain neural signature filling up and draining all the time. Little bits of nociception are produced. Stressful events occur, but if the tubs stay well drained, the pain neural signature does not activate, and pain is not experienced. However, let's say stress or anxiety levels stay high, or our thoughts and mood keep the tubs full. This time when some faucets of irritable signal or even normal sensation turn on, and the tubs aren't drained, they'll overflow. The pain neural signature will activate, pain will be experienced, and all the body's protective responses will be activated as well. Let's take a look at the pain neural signature in action. Imagine someone is walking down the sidewalk and they step on a nail and it pierces through the bottom of their right foot. That irritable signal, nociception, travels along the peripheral nerves, up the spinal cord, and to the brain. At this point, the fact that something has happened to the right foot activates a part of the brain called the sensory cortex. This is the part of the brain that is responsible for processing sensation. It's sort of like the brain's body sensation map. In the sensory cortex, there are little neurons that are dedicated to sensation for different parts of the body. You literally have right foot neurons and left foot neurons and knee, hip, and back neurons. Whenever the right foot sensory neurons are activated, that means right foot to that person's brain. For example, if a neurosurgeon somehow activated the right foot neurons in a certain way, you would feel like somebody was grabbing your right foot even if no one was touching your foot at all. This is why something like phantom limb pain can exist. A person may be missing a right foot, but what do they still have? Right foot neurons. If the pain neural signature starts to become concerned about the missing right foot, it may activate the right foot neurons and the person will experience very real pain in their right foot. Isn't that amazing? But that's not the case for our dear little friend who stepped on the nail. Something is definitely happening to their right foot. But pain has not been produced yet. We have a few other areas of the pain neural signature that get involved before the experience of pain is created. The cingulate cortex and prefrontal cortex are areas involved in problem solving, planning, and focus. They know the sensory cortex is telling them there is nociception coming from the right foot, but they want to be sure there is a real threat before they sound the alarm, because sounding the alarm is very disruptive to the whole brain and body. They then talk to the hippocampus, which is involved with memory, specifically memory of traumatic events. They ask, has stepping on a nail ever been a problem before? Is there a reason I should be concerned about my right foot? The hippocampus then responds, why yes, in my experience when something sharp pierces the skin, it's a threat. The threat assessment areas then sound the alarm. The right foot neurons in the sensory cortex are activated and pain is experienced in the right foot. But that's not all that happens. The motor cortex quickly lifts the foot and begins to guard and protect. The stress and mood centers, the hypothalamus and the thalamus, they activate a stress response, get the fight or flight response going, activate inflammation, and the mood centers are activated. Maybe the person feels frustrated, cranky, and probably a little angry about someone leaving a nail positioned just right for them to step on. The hippocampus reinforces the memory that stepping on a nail is a threat, but now it starts to add the memory that possibly even walking down the sidewalk is a threat, especially when you don't wear shoes. The amygdala and the insula are areas that process fear and anxiety. Now this person will feel a little more hesitant when they walk down the sidewalk, and they will definitely put on shoes before they walk out the door. This is how the pain neural signature creates the experience of pain whenever someone gets injured. It happens automatically and quickly without us even being aware of it. Sometimes, though, the pain neural signature does not create the experience of pain even when tissues get injured. Let's take a look at the same event, but put it in a different context. A person steps on a nail, but this time they happen to be in the middle of the road and a bus is about to hit them. Will that person still feel pain? The pain neural signature might not activate the sensory cortex to create pain in this situation because of the greater threat of being run over. In fact, the pain neural signature may completely ignore the right foot altogether and focus on getting the person out of the way. In this context, creating pain would not be protective. In fact, it may create behaviors that cause even more harm. This explains why we have so many reports from combat veterans and accident victims that say they didn't feel pain when they were injured during a threatening situation. Their pain neural signature was more concerned about the immediate threat. Pain could come later. Remember before when we talked about how nociception is produced with normal events, even if there is no tissue damage or pain? Let's take a look at what the pain neural signature has to do in order for someone not to feel pain during a normal event. Let's say someone steps off a curb suddenly, but there is no tissue damage or injury. The sensory cortex notifies the threat assessment areas that there is a sudden flow of sensation from the foot, knee, hip, and lower back on the right side, and a little more nociception than usual. What do the threat assessment areas do? They assess for threat. They say, well, there's a bit of jarring from stepping off a curb. I did get some nociception from the right lower back, hip, knee, and foot, but I'm not sure if that would cause any damage. Let me see if I have any traumatic memories of this kind of sensory input or those areas of the body. It then checks with the memory centers and wants to know, have I ever had a problem stepping off a curb? Have I ever had any problems or prior injuries to my right lower back, hip, knee, or foot? For this example, we'll say that this person has not had any issues stepping off a curb, and they have not had any severe injuries or issues with those areas of the body. So there is no threat. Now let's see what doesn't happen next. The right lower back, hip, knee, and foot neurons in the sensory cortex do not produce pain. The motor cortex does not produce muscle spasms to guard and protect. There is no stress, inflammatory, fight or flight, or mood response created. The memory that there is no problem with these areas of the body or stepping off a curb is reinforced in the hippocampus. And this person will not experience fear, anxiety, or apprehension about stepping off a curb in the future. But that's not all that happens. The brain takes an extra step that has a big effect. It produces molecules called endorphins and sends them down to the spinal cord to block any more of that distracting nociception. It also passes the endorphin molecules around to all the areas of the pain neural signature to help them calm down. Chill out, everyone. There's no threat. Everything's cool. Everything's going to be okay. This is what the brain has to do for us not to feel pain with normal daily events. But most of you are watching this presentation for the simple reason that you do have pain with normal activity. In fact, you may have pain most of the time. You have questions that need to be answered. The pain neural signature in the nervous system can become sensitized by prior injury or traumatic events. This person is about to step off the curb suddenly too. The same event with no new tissue damage, but this person had a right lower back injury many years ago. As a result, the threat assessment areas place a high threat value to the right lower back. Any information from the sensory cortex about the right lower back has a high threat value as well. In fact, there will likely be a sense of low-level fear and anxiety that is maintained about the right lower back. As you can see, the tubs in this person's pain neural signature may not be overflowing yet, but they are already pretty full. And they haven't even stepped off the curb yet. When they do, what do you think happens? That's right, the alarm sounds. The right lower back neurons of the sensory cortex create pain. Muscle spasms occur at the right lower back to protect. Funny thing is though, muscle spasms definitely create a lot of nociception to add to the tubs. The stress centers activate, activating fight or flight, mood responses, and inflammation. Guess what? Inflammation adds more nociception too. The hippocampus not only reinforces the memory that the right lower back is a problem, but now it adds an activity to the list. A high threat value, fear and anxiety, will be assigned to stepping off a curb now as well. A lot of patients with chronic pain are walking around with the tubs of their pain neural signature full all the time. In fact, they don't even have to step off a curb. There's such a high threat value placed on movement and areas of the body that a cold day, weather changes, or even just thinking about a movement or watching someone else do a movement may be enough for pain to be produced. Anything that causes our threat response system to elevate can sensitize the pain neural signature. There doesn't even have to be areas of prior injury at all. Someone may have just experienced a severe traumatic event or multiple traumatic events, and their pain neural signature may stay in a threatened state. Guarding, tension, or maintain, always vigilant, always protecting, stress, fear, anxiety, they all may stay elevated. Pain is sometimes produced for what may seem like no reason at all. This is why post-traumatic stress can be a big contributor to pain becoming persistent. It's also why working with the right experts to effectively address the stress and other psychosocial factors associated with trauma needs to be a part of your plan of care to address pain that persists. Sometimes there can simply be a change in the processing within areas of the pain neural signature. This occurs in certain types of central sensitization, like fibromyalgia. When this occurs, pain will be produced and assigned to random points all over or sometimes whole regions of the body. There will be areas of increased sensitivity to touch and pressure. Mood and energy levels become affected. This indicates that the pain neural signature itself is in a sensitized state, which is why many medical providers prescribe medications that directly target the brain to treat these types of pain conditions. I wish that I could tell you that the changes stopped there. The truth is, our body, brain, and nervous system are made entirely of living tissues. One thing that is true about living tissues is that they never stay the same. They are always adaptively changing in response to what they are exposed to and the conditions that they exist in. When the pain neural signature starts to reside in a threatened state, it tends to contribute to other changes occurring as well. Thoughts and beliefs increase stress, fear, and anxiety levels. Inflammatory responses are activated, increasing nociception. Protective tension and guarding are maintained, also increasing nociception. Tender points develop within the muscles, which increase nociception. Thoughts and beliefs in a constant pain cycle affect mood, creating cycles of frustration and anger or depression. And all of these together also affect our behavior. And guess what? Behavior will affect everything else. Eating habits start to change. If you want to keep tubs from overflowing, what do? You have to drain the tubs. You also have to turn off the faucets. Sleep is one of the most important tub draining events that can occur. If sleep is affected, the tubs will tend to stay full all the time, and the pain neural signature will reside in a sensitized state. You also may be less likely to engage in activity and exercise. The tissues of the body will become deconditioned and develop new sources of nociception. Healing may be impaired, and medical conditions will be made worse. Remember the endorphin molecules? Guess how they get produced? By exercise and doing things that are fun. If we are not moving, then we are literally depriving our brains of this important pain-controlling molecule. If you remember, the endorphin molecule helps to calm down the pain neural signature and to block nociception. Interestingly, though, there's another molecule used in certain pain medications that is almost exactly the same as the endorphin molecule, but not quite. That is the opioid molecule. This is the molecule that is active in opioid pain medications like Percocet, Vicodin, Dilaudid, Oxycontin, oxycodone, morphine, and in drugs like heroin. When the opioid molecule is in the system too long, though, a lot of problems occur. If the opioid molecule is in the system for even as little as 5 days, the brain will start to decrease the amount of endorphins. Over time, because the opioid molecule is not nearly as effective as the endorphin molecule, pain will get worse, and a person can develop what is called opioid hyperalgesia. Hyper just means increased, algesia means pain. This means that pain has increased over time because the opioid molecule has interfered with the body's natural endorphin pain-relieving system. This is just one of the reasons why medical providers have been giving guidelines to only prescribe opioids for no more than a few days at a time. In addition to opioid hyperalgesia, sometimes physiological cravings and dependence can develop, or at high enough concentrations, opioids can interfere with breathing and cause accidental death. This is especially a problem if there are other factors that affect breathing, like sleep apnea, or if someone uses other substances that affect breathing, like alcohol, benzodiazepine, or marijuana. If someone has been on opioids for a prolonged period of time, and they want to effectively address chronic pain, they should definitely consider discussing a way to taper off of opioid pain medications with their prescribing medical provider to come up with an individualized plan. Chronic pain does not occur solely as a result of irritable signals from the tissues of the body, although they are involved. The problem is, that's the way the medical system has tried to treat chronic pain, as if just finding the right medication, performing a surgery, or injecting a joint would be enough to help. These treatments are only targeting a small portion of what's really going on. This is chronic pain. There are many more contributing factors involved that need to be addressed.
Understanding how our brain produces the experience of pain and how pain becomes chronic is just the first step in effectively addressing chronic pain. Please click on the link to watch part 3 of the pain education presentation. In it, you will learn what kind of plan you and your providers need to develop so you can take control of your pain experience and improve your quality of life.